So it's a real pleasure to have Dr. Emily Haines with us today. This is the second episode of our Systems Change lecture series this year, which has a focal theme around the intersection of implementation science and system science. So we're featuring a number of different speakers coming at this intersection from different perspectives. And today, Dr. Haines is going to share with us some of her work on using design thinking, sometimes called user-centered design or human-centered design, in improving the implementation of evidence-based interventions. Really interesting talk. So Emily is currently a postdoc at the Wake Forest School of Medicine within its cancer prevention and control training program. She has a PhD from the Department of Health Policy and Management at UNC Chapel Hill, and she's an expert on implementation science and organizational science. I came across Emily's work in the cancer arena because the unit where Emily works is they're part of the CDC Cancer Prevention and Control Research Network. And so that's how I initially, got in touch with some of the people that, Emily works with. And I actually just, not accidentally, but coincidentally came across a paper that Emily has been working on that talks about the user-centered design strategies that she has employed in improving cancer care coordination among young adults with cancer. And I just found the paper to be absolutely fascinating. So I immediately emailed Emily and invited her to see if she'd be able to present her work to our audience as part of the Systems Change lecture series. So welcome, Emily, and welcome to all of you. And let me pass the mic over to Emily.
Great, thanks so much for that introduction. Let's see, let me share my screen here. All right, can everybody see my screen?
Yes.
Great. Well, hello, everyone. Thank you so much for joining. I am really excited to talk to you today about my work at the intersection of implementation science and user-centered design. Since not all of you may be familiar with implementation science, I wanted to start off by giving you a quick and dirty overview of the field and highlighting what I see as some current gaps in implementation research. Then I'll discuss broadly how user-centered design can be applied in implementation research. And then I'll end by walking through a case example from my dissertation research on improving care coordination for adolescents and young adults with cancer. So what is implementation science? About 20 years ago, Ballas and Warren wrote a famous paper concluding that it takes an average of 17 years for 14% of research evidence to reach clinical practice. And this estimate has since been criticized, but the fact remains that the translation of research to practice is slow-moving work. And as my colleague Byron Powell says, while we want to see evidence go from the bench to the bedside, what we see more often is it going from the bench to the bookshelf. And the field of implementation science has emerged to address this research to practice gap. And I like this definition from Martin Eccles and Brian Mittman, who define implementation science as the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practices into routine practice, and hence to improve the quality and effectiveness of health services. Implementation science has a broader scope than traditional clinical research, looking not only at the patient level, but also at the provider and organization and policy levels of healthcare. The field has multidisciplinary influences, drawing on fields like improvement science, organization and management, and social psychology, just to name a few. And in recent years, we've seen a growing interest in implementation science from the NIH, AHRQ, and other federal funding bodies, as well as from private foundations and other groups. So this figure walks you through the traditional translational pipeline from formative work to efficacy studies to effectiveness trials, and finally to implementation science, which focuses on how we can make interventions work in the real world. And as you'll see in this purple box in the upper right-hand corner, implementation is often conceptualized in multiple phases. For example, the phases seen here: exploration, preparation, implementation, and sustainment. You'll also see in that purple box a distinction between implementation research and implementation practice, where implementation practice focuses more on local questions, can we make this work in a particular setting, versus implementation research, which focuses more on producing generalizable knowledge. And I'll note here that increasingly we're seeing calls to condense this traditional pipeline and embed implementation research earlier on. For example, some of you may be familiar with the work of Jeff Curran and others on hybrid effectiveness implementation trials. This is a conceptual model of implementation research from Enola Proctor and others. On the left-hand side, we see the intervention or the research product of focus. And this could be a program, a practice, a policy, a procedure, or another product. In plain language, this is the thing that we're trying to implement. Continuing with this plain language framing, implementation strategies are the how, or the stuff that we do to try to help people and places do the thing. For example, we might train providers to implement an intervention, or we might tie performance incentives to implementation. Implementation outcomes tell us about how well people and places did the thing. And this includes perceptual outcomes, like did key stakeholders perceive the thing as feasible and acceptable to implement, as well as behavioral implementation outcomes like penetration, which measures how many people got the thing, and fidelity, which measures whether the thing was implemented as intended. So based on Proctor's model, these implementation outcomes influence service outcomes and in turn, patient outcomes. So now I want to talk about what I see as some current gaps in implementation research. And spoiler alert, I'm setting the stage here for the potential value of applying user-centered design to implementation efforts. So first I want to talk about something that's not captured in this model, and that's implementation context. Context includes those who will ultimately use an intervention, as well as features of the setting in which it will be used. And this is a particular area of interest for me. So this table just shows just a few of the contextual factors known or hypothesized to influence implementation. But despite pervasive findings pointing to its huge role in implementation, context remains poorly understood in implementation science. And this may be in part due to a lack of approaches for measuring context. Many of the approaches that we've seen may be narrow in scope, for example, focusing only on individual level or internal factors, or they may provide only cursory views of complex and dynamic contexts. Thus, we need in-depth and multi-level approaches in implementation research to meaningfully describe the context into which interventions will be implemented. But once you assess context, then what? In order to actually improve implementation, contextual information must be paired with efforts to use that information. And Bonatti described several potential applications of contextual data, including meeting in which interventions or implementation strategies are adapted to align with context, and elevating in which context is modified to make it more receptive to implementation. And using contextual information towards meeting or elevating requires methods for achieving this translation. And those methods are lacking in the existing implementation science literature. So next, I want to focus on some gaps related to this intervention piece. Often, we try to shove interventions into contexts for which they are not well suited. And not surprisingly, this mismatch makes implementation really difficult. We know that the same intervention can have varying degrees of implementation success and effectiveness across different contexts. And this suggests that an intervention's implementation and effectiveness are closely tied to context. Thus, we need methods for considering the complex interplay between intervention and context. Interventions are also rarely designed to address the nuances of multiple changing, very different practice contexts. So there's almost never implementation without some adaptation to local contexts. And yet methods to inform systematic intervention adaptation are kind of in their infancy. And this goes back to the idea of meeting and how we need methods for adapting interventions to align with context. And finally, I want to talk about some gaps related to implementation strategies. To address the discordance between interventions and context, implementation scientists often turn to implementation strategies. However, a more is better approach to deploying implementation strategies can burden intervention users. And to minimize this burden, we need approaches for identifying minimally necessary implementation strategies. Moreover, implementation strategies have often shown only modest effect sizes. And this could be in part due to an insufficient consideration of key determinants like contextual appropriateness when selecting or designing implementation strategies. And to this end, implementation scientists have called for methods for tailoring implementation strategies to context. And again, this goes back to that idea of meeting, which I described earlier. So what do all of these gaps add up to? In thinking about the relationship among interventions, context, and implementation strategies, my colleagues and I created this embroidering analogy, where the black thread represents an intervention, the blue fabric represents the context into which it is implemented, and the red needle represents the implementation strategies used. In this analogy, each component must be considered with respect to the other two. So for example, if you use too thick of thread or too large of a needle, you might damage your fabric. And central to my work is the proposition that harmonizing intervention, context, and implementation strategies can promote implementation. And by harmonizing, I mean considering each with respect to the other two. So how do we accomplish this harmonization? In my work, I propose user-centered design to help us to harmonize interventions, context, and implementation strategies. User-centered design is a collection of methods and principles to guide the development of innovations that are responsive to the needs and constraints of end users and their context. And when I say users, I mean those who will ultimately use the intervention in practice. So in healthcare, this might be patients and providers. In user-centered design, the users of a product or a service are engaged starting from the early planning stages and throughout the development and testing life cycle. And the focus is on understanding users, their goals and tasks, and their environment. The user-centered design has roots in human factors engineering, human-computer interaction, and cognitive psychology. And I'll note here that user-centered design is often used interchangeably with human-centered design. Essential activities in user-centered design include understanding the context in which an innovation will be used, specifying user and organizational requirements for that innovation, generating design prototypes, and then evaluating prototypes against the requirements by testing them among potential users. And importantly, user-centered design is not a linear process, but a cycle in which innovations are iteratively refined based on user interactions with them. So two primary outcomes of interest in user-centered design are usability and usefulness. Usability is the ease with which patients and providers can use an intervention in practice. And usefulness is the extent to which an intervention accomplishes its intended goals. And I'll talk more about these outcomes when I talk through my case example, but I did want to note here that usability has been proposed by my colleague Erin Lyon and others as a proximal determinant of implementation. So for example, if an intervention is more usable, then key stakeholders might perceive it as more feasible, acceptable, or appropriate to implement. And this in turn can influence behavioral implementation outcomes like adoption and penetration. So given that usability is a primary outcome of user-centered design, and if usability is indeed a key determinant of implementation outcomes, then this supports the potential value of applying user-centered design to implementation efforts. But now I want to bring us back to the embroidering analogy that I touched on earlier. How exactly can user-centered design help us to attend to each component of this analogy? And I'm going to walk through each component and discuss really broadly how user-centered design can be applied. And I'll throw out some examples of user-centered design methods just to kind of give you a broad sampling, but then I'll hone in on some more specific methods when I go through my case example. In thinking about the intervention, user-centered design offers methods for selecting interventions that are more contextually appropriate. For example, you might leverage measures of usability from user-centered design, such as the system usability scale seen here, to evaluate a potential intervention's usability before implementing it. User-centered design also offers methods for adapting interventions to better suit context. For example, you might conduct a heuristic evaluation in which a small group of users evaluates a product's compliance with recognized usability principles like the ones listed here. And this method can help to identify an intervention's design limitations to target with adaptations. In terms of context, user-centered design offers methods for generating in-depth descriptions of context. For example, you might observe users in their own environment using contextual inquiry methods from user-centered design, or you might use diary keeping in which users record their tasks and experiences related to the product of interest. And user-centered design also offers methods for modifying context to make it more receptive to implementation. For example, you might use workflow mapping to modify workflow to accommodate intervention implementation. Once an intervention is adapted to align with context and context is modified to promote receptivity to that intervention, remaining gaps between intervention and context can be targeted by implementation strategies. And in terms of implementation strategies, user-centered design can help us to anticipate needed strategies. For example, you might conduct design team workshops to review contextual data and identify areas where fit between intervention and context is low, and then problem solve accordingly. User-centered design also offers methods for selecting strategies that align with intervention and context. For example, my colleague Erin Lyon and others developed the cognitive walkthrough for implementation strategies to inform the selection of strategies with high usability. And finally, user-centered design offers methods for designing or tailoring implementation strategies to context, for example, through conducting co-creation sessions with users. So to make some of this more concrete, I'm now going to kind of walk you through a case example from my dissertation research on improving care coordination for adolescents and young adults, or AYAs, with cancer. So first, I'll give you some background information on the project and kind of why we opted for a user-centered design approach. So in the US, nearly 90,000 AYAs ages 15 through 39 are diagnosed with cancer each year. And there's a large body of literature to show that AYAs have unmet needs. We know that their needs are age-specific, varying from those of children or older adults with cancer. They're multifaceted, spanning across physical, psychosocial, and practical domains. They vary from one AYA to the next, and they fluctuate as AYAs move through treatment. We also know that these unmet needs have been associated with poorer experiences of care and worse health outcomes for this population, including higher distress, lower health-related quality of life, and higher physical symptom burden. But despite the scope and complexity of their needs, AYAs often don't use services available to them through their cancer care programs, even when they don't face any access issues like cost, insurance status, or local service capacity. AYAs report several barriers to service use. For example, you can imagine the sheer volume of information that they receive upon diagnosis and how sifting through all that to find information compatible with their own needs may be too daunting a task. The type of barriers to service use listed here point to a need for improved care coordination for this population. And effective care coordination requires first identifying a patient's needs and then connecting them to services or resources which address those needs. And this, in theory, should result in fewer unmet needs. So given that AYA's needs are an individual and moving target, how do we effectively assess them? Well, a few years ago, some folks in Australia developed the Cancer Needs Questionnaire Young People, or CUNY, which is the first holistic needs assessment designed specifically for AYAs. But the CUNY is pretty long, pretty complex, and it has some other usability issues that we decided needed modification. But the biggest problem with the CUNY is that once needs are identified, it lacks a subsequent process for using that information to drive service delivery. In other words, the tool by itself has low actionability or low usefulness for improving care. So to this end, using the CUNY as a foundation, we developed the AYA Needs Assessment and Service Bridge, or NASB, to connect AYAs to the services that they need. NASB includes a patient-reported outcome measure assessing AYA's physical, psychosocial, and practical needs, as well as a collection of referral pathways that are triggered depending on the needs that AYAs report. However, we knew that the ability of NASB to coordinate care and reduce unmet needs would depend on its acceptability and appropriateness to AYAs, a population with high rates of non-adherence and low rates of participation in supportive services, as well as the feasibility of its implementation in cancer care programs where a number of barriers to care coordination exist. For example, there are sometimes turf wars between pediatric and adult oncologists when it comes to AYA care. So in light of these multi-level barriers to change, and in light of the usability and usefulness issues that we identified with the CUNY, we leveraged user-centered design to help us design NASB. We employed this three-step user-centered design process to develop NASB. Because we started with an initial prototype, the CUNY, we started with this review and refine prototype step. The second step is understanding users and context. And by users, I mean AYAs and providers. And in terms of context, our implementation context was the University of North Carolina Lineberger Comprehensive Cancer Center. And our scale-up context was other AYA programs in the United States. Finally, in the third step, data from the previous two steps are used to generate design solutions, or in this case, a NASB prototype and plan for implementation. So we integrated that three-step user-centered design framework into Proctor's conceptual model for implementation research, which I described at the beginning of the presentation. So per this model, leveraging user-centered design to design NASB for implementation in context should promote its usability and usefulness, and subsequently its achievement of target implementation, service, and patient outcomes. My three aims correspond to the three steps of the user-centered design process that I previously described. So to refine the CUNY, we leveraged usability testing, including a survey, cognitive interviews, and concept mapping. To understand users and context, we leveraged ethnographic contextual inquiry, including guided tours and semi-structured interviews. And then finally, we use data from aims 1 and 2 to design NASB and plan for its implementation through 2 design team prototyping workshops. User-centered design demands an active and iterative approach to stakeholder engagement. often with the same group of users reviewing prototypes at multiple time points. In fact, a key element of user-centered design is the collaboration of a multidisciplinary design team to generate design solutions. And we convened our design team comprised of provider and AYA representatives at the onset of the project, and they were engaged throughout. For example, they helped with recruitment, they helped with the development of data collection instruments, and of course, they helped us to interpret study data to generate design solutions. So first, we conducted usability testing to refine the CUNY with a focus on improving its usability and usefulness. So for a needs assessment, usability includes things like, do AYAs understand the questions? How long does it take them to complete it? And are they okay with that? Do providers have the tools that they need to administer the assessment? For a needs assessment, usefulness includes the extent to which information collected on the assessment is actually linked to service provision. I remember when my dad was undergoing cancer treatment, he became increasingly frustrated by the battery of assessments that he was asked to complete by his providers. And convinced that no one was doing anything with that information, he started to check off all of the most catastrophic boxes on these surveys just to see if anything would come of it. But nothing ever did. No one ever followed up. And I tell this story just to kind of highlight the importance of usefulness for this project. So in usability testing, products or services are evaluated by testing them among potential users. And participants must represent real users, and the researcher has them complete representative tasks. So first, we disseminated a survey to AYAs around the country. And the purpose of the survey was to identify AYA preferences for a needs assessment using the CUNY as a prototype for them to react to. So participants were asked to complete the CUNY in its original form, and then they were asked to evaluate its usability. Next, we conducted cognitive interviews with AYAs from around the country to get more in-depth usability data. And during these interviews, we walked section by section through the CUNY, and I asked AYAs to think aloud as they read and reacted to CUNY items. Third, we conducted concept mapping with providers from around the country, in which participants were asked to sort a list of needs derived from the CUNY into what we called follow-up domains based on the service expected to address them. So for example, feeling depressed and feeling anxious might be sorted together as potentially addressable by a referral to a mental health professional. And the purpose of this was to inform our grouping of needs in the assessment and promote the usefulness of NASB by creating an intuitive link between needs and services. Concept mapping participants also rated each need in terms of its importance and actionability. So I'll note here that although concept mapping is not a traditional user-centered design method, its utility for triangulating across diverse stakeholder groups makes it very much compatible with the objectives of user-centered design. So we then engaged our design team in a prototyping workshop where we used usability testing data to refine the CUNY and generate our NASB prototype. Important to user-centered design is the visual and interactive presentation of data for stakeholders to interpret. So for example, in this workshop, I created a deck of cards, each representing items to consider eliminating or revising. And each card included usability testing data with respect to that item. And during the workshop, design team members interacted with these cards and used stickers to vote on whether to eliminate or revise items. Also during this workshop, I used cluster comparison worksheets that look like this to help the design team to interpret the really kind of complicated concept mapping data. So I'm not going to go into detail here, except to say that we made a number of changes to the CUNY. We added missing content, such as items on sexual health. We removed unactionable content, needs like feeling frustrated. They're not easily addressable by a service. We revised confusing or unpalatable items, and we streamlined the tools, response options, and sequencing. Perhaps one of the most important changes that we made to the CNQYP was grouping needs by services expected to address them. And this goes back to the idea of usefulness. And we use concept mapping data to help us to do this. The concept mapping software generated this point map where each point represents a need. The closer 2 points are in proximity, the more often those needs were grouped together by concept mapping participants. And the software also creates a number of different cluster solutions, which group the needs on this map into different numbers of clusters. And the design team considered these various cluster solutions during our workshop and ultimately landed on the 8 cluster solutions seen here because we felt that it best grouped needs in terms of services to address them. We split 1 cluster into 2, resulting in 9 follow-up domains. And the design team labeled those domains as seen here. The design team then linked each of our follow-up domains to a referral pathway that items in that domain should trigger. For example, items in the information domain trigger kind of a follow-up with the primary oncology team. And by connecting needs to services, we created a tool that is useful for care coordination. And this is just to give you an idea of what the revised needs assessment looks like. Once we had revised the needs assessment, we turned our attention to how it might be implemented and delivered in practice. And we used ethnographic contextual inquiry to identify contextual factors that should be considered in the design and implementation of NASB. In contextual inquiry, in-depth data on a few carefully selected individuals informs a fuller understanding of users and their context. And ethnographic methods can be particularly useful for contextual inquiry, given that its key premise is observing users in their own context. So our ethnographic approach included guided tours with AYAs and providers from UNC. And during guided tours, which are kind of like a blend between observation and interview, I followed patients and providers through the clinic, asking them questions about their tasks and interactions as we went. And although guided tours require a flexible and unstructured approach to interviewing, such that the participant is in control, we did develop a repository of questions in advance based on the 4 domains of McGuire's user-centered design framework, seen here. We also conducted semi-structured telephone interviews with AYA providers from outside of UNC, just to ensure that we weren't developing a tool that is only applicable to UNC. User-centered design often involves some sort of translation of contextual factors into usability requirements, where the characteristics an intervention should have to be usable in practice. And we used ethnography data to generate a list of requirements for NASB, and this slide shows just a few examples. So for example, let's look at this second row. During my guided tours with AYAs, I saw how long and exhausting appointments can be. It became increasingly clear that tacking on any additional time to administer NASB would not be acceptable to AYAs. I noticed, though, that there were multiple periods of waiting time during a typical appointment, waiting for labs, waiting for the oncologists, and so on. And thus, I landed on the requirement here that if delivered in person, NASB should be folded into these periods of appointment dead time, so as not to prolong AYA's already long and exhausting appointments. And this list of requirements would be used by our design team during our next workshop as we figured out how to deliver and implement NASB. Finally, user-centered design offers methods for translating usability requirements into context modifications needed to facilitate intervention delivery. For example, during the second workshop, we leveraged some prototyping methods from user-centered design. For example, we used a storyboard that looked like this to walk through the various pieces of NASB delivery And for each piece, I primed the design team with relevant usability requirements, and then we collaboratively specified the context modifications needed to deliver NASB. For example, changes to provider workflow or changes to documentation or communication systems. We then vetted what we came up with personas like these, which were developed based on ethnography data and allowed us to consider various user groups in a really concrete way. So for example, these two personas allowed us to consider AYAs with frequent inpatient stays and AYAs with infrequent appointments to ensure that NASB accommodates these different user groups. And finally, we used a user-centered design method called scenarios of use to vet our delivery specification against the various types of appointments that AYAs might have, as pictured in this flow chart. So for example, one scenario of use included treatment and a clinical visit, while another scenario included just treatment. This slide gives just a few examples of context modifications that we identified. To the extent possible, we wanted to align our intervention with its implementation context and minimize the contextual modifications needed to deliver it. In thinking about workflow changes, for example, it was really important for us to identify the skills and expertise of various AYA team members, and then leverage those skills and expertise towards delivering NASB. For example, the AYA social worker at UNC was the one who was responsible for assessing and addressing AYA's needs, albeit through a more informal conversational approach. Thus, we opted to embed the NASB care coordination piece into her routine follow-up visits with AYAs, so as to leverage her existing workflow and expertise. Once we'd adapted our intervention to align with context and identified modifications needed to deliver it, we sought to address remaining gaps between intervention and context by anticipating implementation strategies needed. We used ethnography data as source data to generate a list of potential outstanding barriers to NASB implementation. We then leveraged our design team to prioritize these barriers and collaboratively identify implementation strategies to address them. And this figure shows the design team's ranking of potential barriers from most to least salient. For example, this top barrier is related to NASB's interface with the electronic health record. To address this barrier, the design team decided to use a pilot test to explicitly map out changes needed to the EHR to facilitate more systematic documentation of NASB, for example, through building in a flow sheet. These next two barriers are related to patient heterogeneity and the capacity of AYA social workers to respond to needs. And to address these barriers, the design team opted for a phased-in approach to implementation, starting with one disease group and expanding outwards. Other anticipated implementation strategies included identifying an AYA champion in each department to strengthen NASB referral pathways, and also building flexibility into service options to accommodate the preferences and scheduling constraints of AYAs. So just as embroidering requires compatible thread, fabric, and needle, implementation may be optimized by harmonizing intervention, context, and implementation strategies. And I acknowledge that this analogy is not perfect. For example, some might regard embroidery as mere decoration or embellishment. And on the contrary, our intention with this analogy is to convey the integration of the thread such that it becomes part of the fabric itself. Despite its imperfection, this analogy is useful because it urges implementation scientists to attend equally to features of interventions, context, and implementation strategies. And doing so has the potential to limit the challenges associated with kind of exceedingly complex interventions or implementation strategies that burden stakeholders. In this study, we leveraged methods from user-centered design to harmonize intervention, context, and implementation strategies. And I now just want to kind of touch on some benefits and challenges associated with each of the methods that we used. So in this case example, usability testing elicited user concerns about the CUNY that might have limited its uptake in practice. And this allowed our design team to redesign the CUNY to maximize its usability and usefulness. And by addressing these usability and usefulness issues up front, we designed a tool that is to be more feasible, acceptable, and appropriate to users. One appealing thing about usability testing is that it can be done with a small number of participants, as few as 5 to 10 users. However, this places issues of sampling at the forefront, making decisions about who counts as a representative user really, really important. Despite its potential for illuminating complex and dynamic contexts, immersive methods like ethnography have rarely been used in implementation science. And in this case example, we found our ethnographic approach to be extremely helpful in understanding some of the multi-level, hard to quantify contextual factors that might influence NASB's implementation and sustainment. For example, guided tours offered key insights on provider and patient characteristics and tasks, while also capturing other dimensions of context, such as organizational culture, funding constraints, and readiness to change. And the rich data that we gathered could not have been done through surveys or interviews alone. There are a number of challenges to conducting ethnography, some of which I've listed here. And I wanted to highlight this last challenge with a little anecdote. I was on a guided tour with a 21-year-old AYA with liver cancer. And in the waiting room, her and her boyfriend enthusiastically told me about their plans to move to another state and start a new life together. But when the oncologist arrived, it was with bad news. She told the AYA that her treatment hadn't worked as they had hoped and that her cancer was terminal, and that she had only months to live. So as a researcher, I felt completely unprepared to bear witness to this conversation. And, it served up an important reminder that for some AYAs, cancer is more than just a temporary hurdle. And in fact, we developed one of our personas to represent this particular AYA just to make sure that NASB accommodates AYAs at the end of their life. But I tell you this experience just to make the point that ethnography urges us to go deep, and that can be hard. And in this sense, I think that ethnographic contextual inquiry demands sensitivity, compassion, and a willingness to connect with others on a deeply human level. In implementation research, user-centered design can help us to operationalize our commitment to stakeholder engagement, providing discrete methods for engaging users from start to finish. For example, our multidisciplinary design team reviewed ethnography findings to ensure that the user interpretation of context remains central, as opposed to relying solely on the researcher's interpretation of contextual data. So while our ethnography provided valuable source data for workshop materials, the prototyping workshops allowed us to leverage the expertise of our design team and prioritize contextual factors to target with intervention redesign, context modification, or implementation strategies. One challenge associated with this collaborative format in which multiple different user groups have a seat at the table is the potential for feature creep, in which new ideas are incorporated into intervention prototypes without kind of careful consideration of their implications. And in the context of implementation research, this can raise concerns about diminishing fidelity as products are iteratively refined to align with users and their contexts. As far as next steps for NASB, we are gearing up for a pilot study at the University of North Carolina. In keeping with the iterative nature of user-centered design, pilot data will be used to further refine the intervention. The next phase is thinking about how to scale up NASB to diverse practice contexts. NASB has already been adopted by a couple of cancer programs around the country, but I'm interested in taking the implementation guidance that we developed in this study and expanding it or refining it to be relevant across diverse settings. Another thing I'm interested in moving forward is further teasing out the role of user-centered design and implementation research. And specifically, I hope to empirically test the relationship between user-centered design, usability and usefulness, and implementation outcomes. I'm also interested in delving more into the potential of user-centered design so far as designing or tailoring implementation strategies. In this study, our design team just used contextual data to anticipate needed implementation strategies. But I think that user-centered design methods have a lot of promise for actually developing multi-level implementation strategies that are tailored to their context of use. Another broad interest of mine is the application of ethnography for assessing context. And as I mentioned before, I think the field of implementation science is in need of methods for measuring context and using that information to build parameters for interventions and implementation. And ethnography, which has rarely been used in implementation science, represents an exciting approach for doing this. And with that, I will turn it over for questions. I'm happy to answer questions now, and please do feel free to email me or contact me via Twitter. Yeah, thank you.
Thank you so much, Emily. That was really terrific. So we do have some questions from the audience. I'll lead off with one question, and I think it's kind of similar to this one question from Ray in the audience. When you were talking about clustering the different needs, particularly with an eye towards the kinds of services, that may be leveraged and connected, to serve, specific clusters. You mentioned that, some of the items were sort of scratched, because they weren't like immediately addressable, presumably meaning that they weren't immediately addressable by the way that services were being were set up already in the system. Did you uncover, like in thinking back, were there, needs that you uncovered that, were real needs, but that there were just no services available, right? And so potentially like new programs, new services, new products may actually need to be created, in order to address some of those needs for which we have no solution right now. And so Ray was asking about whether, how are we sure that we are actually tackling the right problem? Or, are we just bypassing, some real problems because we can't solve them right now?
Yes, that's an excellent question. So when we were developing the tool, we did err on the side of comprehensiveness. And when we were looking at needs that were unactionable, we were, the best example I can think of is that one of the CNQYP items was, I feel frustrated. And while that is a valid need, it might not be kind of addressable by a service in the same way that, other psychosocial items like feeling depressed or feeling anxious might be. But you make a really good point in that while UNC is a really well-resourced cancer center, I can imagine smaller community hospitals using this tool and not having services available to address all the needs listed. And that raises the question, do we modify the assessment so that, we're only asking about needs that we can address? Or do we build our program to kind of address these needs that we didn't have the capacity to address before? So I think that we erred on the side of comprehensiveness in also trying to weigh that with burden of having, to complete a long survey. We knew that wouldn't be possible either. So it was kind of a fine line to walk, I think.
Thank you. And I guess, one of those needs, especially as you move into, diverse settings beyond the, Cadillac, UNC Cancer Center kind of setting, you may run into issues of trust, trust between the patients and the providers, Maybe there are even trust and communication issues, within, families, that are accompanying the young adults or adolescents, during their cancer journey. Do you see that, as a potential barrier? And if so, how might one go about addressing that barrier?
So you're saying the barrier of trust in.
The barrier of trust, the barrier related to communication. Well, for the first part of the question is, you see that as a potential barrier, especially as you move into diverse settings. And then secondly, do you think that the field as a whole needs to undertake kind of a design thinking process to potentially ideate and prototype new solutions, to help address these trust or communication related issues?
That's a really interesting question, and something, the current assessment kind of gets at communication, feeling heard by providers and some aspects of communication, but I think that construct of trust maybe isn't fully captured. So that's an interesting question, and I can see that being a definite barrier to optimal care for this population in particular, and something that we'll have to think about as we move forward with implementation.
I'll link two questions from two different audience members into one. It has to do with kind of maybe stepping back and explaining a little bit more sort of the difference between implementation science research and translational research, and also tying in sort of, maybe you can just say a little bit more about like how generalizable this approach is, to a broad range of health or other topical areas.
Well, I'll start with the latter question. I think this user-centered design approach is broadly applicable, and in fact, it has been used in many different disciplines. So I think that some of the methods for just engaging stakeholders in a really concrete way and generating products from that engagement is something that can be applied across any discipline. And then to the first question of, I don't know exactly how to answer that in a really eloquent way, but I think that implementation research is concerned with the translation of research to practice, and I'm not sure as far as what the official definition of translational research is. You might be able to speak to that more than me, Dr. Wan, but implementation research is inherently translational.
Yeah, I think that there's definitely a nice Venn diagram here. I think that implementation science for me, contributes to the translational process. But there are also other areas of science, like dissemination science, for example, that is also part of translational research. And so I think translational research in some ways is a bigger umbrella within which there are different frameworks and techniques that could be employed to serve the translational goal. One last question. I think Ray, yes, I'm sure. So Ray's asking whether, folks here and you, Emily, in particular, have reviewed ideas of design thinking in the business arena. And he mentioned Roger Martin at the University of Toronto specifically. I'm sure the answer is yes, because a lot of design thinking, did stem from the business management field. And the Stanford D School has a lot of design thinking resources that folks in the audience, if want to kind of look more into this, could just Google Stanford D School design thinking. You'll pull up a lot of different resources that are freely available. We did have one earlier question about the sort of sampling aspect of usability testing and the ethnographic inquiries. The question had to do with sort of pointing out that the samples were quite small, and the the person asking the question was wondering if you felt that you were able to really achieve saturation. Did you really get enough understanding of the kind of scope and perhaps diversity, heterogeneity, of the problems that patients were facing or providers?
Yeah, so a couple of things. Usability testing, as I mentioned, can be done with small numbers of participants. And I think that, we did for the cognitive interviews and the ethnography and the semi-structured interviews, we recruited until we felt we had reached thematic saturation. That was kind of our stopping point and sort of keeping with best practices for qualitative research. I think that, I was shocked. I'll speak to the guided tours specifically, which, we did with 2 providers and 8 AYAs. I was shocked at the breadth of information that we achieved just through that small of a sample size. And, not even just, like I mentioned, not even just individual level information, but information about the organizational context and whatnot. So I think that in my experience with this study, it was sufficient to kind of achieve the breadth of information that we were looking for. That being said, the ethnography was very focused on UNC. So obviously, you're looking at differences across contexts as well.
Mm-hmm. And also, Emily, I mean, design thinking, oftentimes the emphasis is really understanding, is to allow insights to emerge from a deeper understanding of the extreme cases, but in both directions, as opposed to like the average user. And so the way that design thinkers, think about sampling or who they might prioritize, to interview or to observe is a little different than how public health people think about sampling. Can you say a little bit about that, how that factored into your research design?
Yeah, I'm glad you mentioned that, because with those small samples, it was very important for us to really purposefully sample. And I think that, for example, it was really important for us to shadow AYAs both in adult and pediatric oncology, because the difference between those contexts is very different. And also in achieving kind of variation across race, ethnicity, age group within the AYA age group. And, having kind of that broad sample within our small sample was something that we were really, really intentional about. And you really have to be in user-centered design if you're using a small group of users to represent users more broadly. Like I said, that places issues of sampling at the forefront.
And in your sample, did you have patients, for example, who were, coping really well, in terms of their needs versus those who really had trouble getting their needs met?
Yeah. Our clinical partners kind of hand selected our guided tour participants, and we're able to think about things like that, like who's just kind of sailing through the system, no problems, and then who is, more importantly, who is really struggling and kind of needs the connection to these resources and can speak to that side of the experience. So I think that having our clinical partners there, being really intentional about recruitment happening in the clinic was really important.
Wonderful. I think that those are all the questions. So we're right on time. Emily, this was really a terrific talk. I think you did such a wonderful job, sharing kind of the, not only the overall concept and what, user-centered design could do for public health and healthcare, but also providing real examples of how this can be done, so it's really, really insightful. And I think it nicely illustrates our center's mission, which is, really to advance the convergence of different frameworks, different tools in service of systems change in public health and in healthcare. So this is an area that we're definitely very passionate about ourselves, and we're so happy that we found you and can learn from your work. A big thank you to the audience for joining us today. Please stay tuned for upcoming webinars as part of the Systems Change Lecture Series. We will continue to explore different dimensions in terms of this crossroads between system science and implementation science, and how we can really transform public health and healthcare moving forward. So thank you all very, very much. Please be in touch.
Thank you very much, Dr. Emily Haines. Thank you very much, Dr. Terry Huang. Please, everybody, stay in touch. Just want to thank the Center for Systems and Community Design, the CUNY School of Public Health, and the NYU-CUNY Prevention Research Center that helps make all of this possible. And please stay in touch for our upcoming sessions. We'll be in touch, and you could also go on to cunycscd.org for other updates. Thank you so much. All the best.
Thank you. Thank you very much.
Thank you.